First we'll go over the G-tube flushing. We don't actually have a G-tube here to show you, but they're very similar to a Foley catheter. Have you all worked with Foley catheters before? Mm-hmm. Okay, so it's the Foley catheter, and then we usually use 30 to 50 cc's, and it does not need to be sterile water, so you could reuse this over and over again. And you would, of course, wash your hands. And if you care to, wear gloves. Everybody's thinking they need to wear gloves. I'm kind of old school, so if I absolutely don't have to, I really don't like to, but you didn't hear me say that. And so you would just unclamp the G-tube. Maybe you want to help me and tell me.
From what I remember, check for residual.
Okay.
And then if there's not, then you do your flush of 30 to 50 first. Are we just cleaning or are we feeding? Or
we could be doing either.
So for the feeding, then once you flush it, then you feed and then flush it again. Or medication's the same thing.
Okay. And then clamp it?
Yeah, of course, clamp it back.
Okay. So
This is for G2?
pardon me?
It's a G2?
Mm-hmm.
Yes, this is for a G-tube.
Mm-hmm.
Actually, if you want to know the truth, this is not the right tip. We need a longer tip that's kind of in a cone shaped, because this will just squirt all over the place. But this is what the syringe looks like. The tip is just a little bit different. So what do you think would happen if you push this in and you felt some resistance?
There's something clogging it.
Okay, so then what would you do?
Try and pull out, see what's in there.
Okay, and then if you push it again and you would still be getting some resistance? Help, nurse, help!
Call the nurse. I'm not doing anything anymore.
Okay.
Yeah, you
Good.
get in trouble.
If you're not
if
sure,
you're doing it
you're
right.
not sure. And the reason that the main reason that we would flush a G-tube would be, what do you think?
Clean it.
To clean it, and why would it get to, I'm a very much a why person. I have to see things very clearly in my
You
head.
get an
So
infection in there.
that could be one reason. The feeding tube liquid, or whatever they're giving in the enteral feeding, can get stuck to the inside over time, and you don't want that to collect bacteria, and you don't want it to get so stuck in there, so that would be why we would be flushing. Any questions on that? Pretty simple, I guess. Okay. And this all sterile stuff in here this is for catheter flush, I think, but we're not going to do that today.
I have a question. We are CNA right now, no? And I need to know, for example, I have a G2.
Mm-hmm.
Sometimes it's have some infection around
The
because
site?
of bacteria. Yes, in the site.
Mm-hmm.
We don't have authorization for clean that. Yes,
Oh, well, this is not a...
because
go ahead.
yes, because they in the facility before work in the facility, and they saying this is for LBN because we don't have a authorization license or something like that. I don't know.
Okay, well, what I would say is if this is a brand new G-tube insertion, the patient's had it, say, within the past couple of months, and you notice that there's a problem, I would have the nurse give you permission, or ask the doctor, or ask the nurse to ask the doctor, like, who would be doing that. If it's a G-tube that's been in somebody for a really long time, usually it's well healed, it's not red, it's not draining, then what you can do is just pretty much, it's not a sterile area. You can just clean it with soap and water.
Okay.
And a lot of times people don't even wear dressings. Oh, I did see those dressings here. I opened one of these. In the beginning, when they first have it, they have the
Yeah.
around there, and they'll ask you sometimes to put on some kind of an ointment or a lotion prescribed by the doctor, but generally it's just soap and water. They usually have these on hand. If every once in a while maybe there is a balloon that's inside that prevents all the stuff from leaking out. If it does start leaking and you need to notify the nurse about it, or the doctor, you might want to put one of these around there to kind of catch it, collect it until you can get that taken care of.
I used to clean mine. I used to have a patient, but the husband used to tell me just clean it like with the alcohol swabs.
Well, alcohol swabs, especially if it's a new one, is going
They
to
was
burn like that.
old. It was old.
That can
already.
be-
She already had it for a while. She was bedridden. She had that G2.
Alcohol can be very drying. Soap and water is really, I think, for all intents and purposes, good enough. Patients' skins are very sensitive to alcohol. I mean, if it's something that you absolutely need to clean all the germs off of, you don't really need to worry about that too much right there.
We would use half saline and half hydrogen peroxide.
Yes, that's good, because that's
Okay.
non-toxic to the skin, you could use
Yeah.
that too. But in a pinch, if a patient doesn't have that in their home, you could
Yeah.
just. Any questions on that? I brought myself a couple of notes. This is the first time, by the way, that I'm doing an adult class. I've been a preschool teacher for many years, so I'm teaching grown-ups now. This is kind of fun. You guys are paying attention, right? I don't need to draw you in or put you in timeout. So I wrote myself a few notes here. So then most G-tubes will have either a plug or a clamp after you're done with the feeding, unless they're continual feedings. You're all familiar with that, okay? And raising the head of the bed with the feeding, 45 for an hour or so after the feeding, and then you can lower their head down. So that's just so that it doesn't kind of come up this way. Okay. So
I think it's a good idea, the training with the G2, but the real G2 we need to see. In my case, because I don't do it never before.
okay.
I never do it before.
Note to Dylan and self. Request for
We didn't have that.
G-tube
We didn't
feeding.
get a.
G-tube
Exactly.
feeding procedure. The
Uh-huh.
whole
The
thing.
whole procedure.
What the tube looks like and everything.
Yeah, because they was duty for the LBN and the facility. I never touched that. We don't have a
Facility
authorization.
regulations are a lot different than what you're going to be doing
exactly.
for the
Home care is
in-the-house.
different.
But in terms of home care, we probably want to, before we place you on a G-tube case, we're going to do actual physical training.
Exactly.
Yeah, and you got to remember too that it's the doctor who set the G-tube, right? Who set it in the patient,
But
and then the nurse is going to be there in the beginning to train, whether it's a caregiver or a family. So, Katie's right. I mean, you're never
But,
going to go to a case where you're not trained on exactly what it is and how it works.
I don't talking about that. Put the tube and there.
No.
Just check when is correct.
And Emma, that's what we're saying is that when we place you on a case in the home, we are going to be training you on how to hook the tube up to the G-tube site, okay?
Okay.
What time the feedings are supposed to happen and all those things. If it's a brand new G-tube, it's very rare that we're even going to be touching it because there's going to be a nurse involved. It's usually when the patient has, the reason why we're talking about the G-tube right now is because we've had clients that have had G-tubes in the past that they're not actually using anymore. They've developed the strength back in their esophagus to go ahead and start swallowing again. So, and eating food by mouth at this point. But they still have the site. And a lot of doctors keep it there because just in case this happens again.
Okay.
So you don't have to go through the re-trauma of doing it all over again.
Okay.
And I don't even know if it can be done twice. But
Yeah.
that's why. So the flushing,
Good.
even when it's not being used, you still have to clean it. You still have to flush it. You still have to do all these things.
And you probably would be flushing it more often if it was being used intermittently than if it was on a continual drip from a bag.
Okay.
But please don't ever do anything that you feel uncomfortable, that you don't absolutely are not sure that you know every little in and out of what you should do. Don't be afraid to tell anybody, I really need help with this, or I need a review or something like that.
Okay, perfect.
You'll much more respected for asking questions than for taking it upon yourself to do something that you're not sure about.
All right.
Okay, so we'll move on to the urinary drainage bag. Who hasn't seen one of these gross? So there is a catheter attached to the end of this, yes, that goes into the patient. Okay, so let's just talk about the urine that's going to be in here first of all. You're all familiar with this, you two? Okay, so the measurements on here, my experience is that they're not really accurate. If you really need to have very accurate readings, usually we have one of these things called a graduate cylinder or the hat. Because, if you hold this up there and you squeeze this, it'll go down. If you let go, have you had that experience? Yeah. So this is not the most accurate reading. For ballpark, it's okay. So, sorry. Were you going to say something? Okay. So let's just talk real quick about the urine that's in here first. You're going to make some observations about the urine. What? Anything else?
It's not cloudy.
Pardon me, yes, cloudy, that's right. Which would, we call that a clarity, I suppose, clear or not clear. Smell, very good.
Some people pass kidney stones in those bags.
Okay, so you're gonna watch for
I
that as
haven't
well.
seen that.
I'm sorry?
I haven't seen that.
Well, they're usually little itty bitty
Little
teeny,
really
little
small
tiny rocks. And sometimes the patients will let you know, oh my gosh, I feel it
back
coming.
pain, yeah.
So, okay.
Yeah.
That's pretty much all what I have. So the things that would be abnormal would be, opposite would be cloudy, stones, sediment, they call it sediment, little floating things in here sometimes.
Blood.
Blood,
Blood,
pink or red, even pink is something to be reported.
Yeah.
How about really, really dark urine, almost a brown?
Amber.
What does that mean?
Infection.
It could be
Dehydration.
Dehydration means that they need to get more fluids if they're
Some-
allowed, unless
some
they're
kind of food.
some kind of food.
Yeah.
Well, you might get the smell of asparagus if you.
No, some kind of food. For example, the oh my gosh, what is the name? The red one.
Pomegranate fruit.
No, it's for salad. It's,
Tomato?
no, it's
Changes the
beet.
beets. Changes the color of the urine.
It's red.
Changes the color of the urine.
Yeah.
I've
That's
never
a,
heard of that.
that's a new one. I mean, shoot, anything's possible, but more than likely, it's probably something
Or some
worse.
medication too.
Medications can't. That's fit. Ooh, I better write that down. Thank you. Yes, yes, yes. Medications can do that. It can change it blue. It can change it also pink. If it's
Pink
especially
and
if it's a
orange.
especially if it's a medication for urinary tract infection, right?
Yeah, it's like this color.
So that could be that patient's normal because of the medication, but you still want to note that. You still want to make a notation of that. Okay. And then there may be some complaints from the resident that might indicate a problem, which might be they might start feeling a pressure in the lower bladder, even though there's urine coming out of here. If they feel pressure down here, what do you think that means?
Main it could mean there's something.
Pinch, cords pinch, maybe?
It could be the
The
catheter is kinked
it's
like
not
this,
working.
or it's compressed like this, or what else could it mean?
Isn't it time when you have to change it? Put a new one in there?
Yes, and I don't really know exactly what the procedure is for that. How often is usually dictated by the facility.
I think it used to be like once a month. The nurse LBN used to come in, Livingston used to come in and change it on my patient.
Once a month.
The tubing,
Uh-huh.
they changed the tubing and used to wash it and rinse
I
it
think
out.
they
really.
even now change the catheters.
I think it's
every
more
so
often. More
Because
often. It's,
So it mine's
once a
been a
month.
while since I was with her.
The bladder infections, I mean, especially in the elderly, are just so
Crazy.
rampant. Yeah, that's the number
I
one.
don't know how often, but it's more often though. Once a month. I think so.
I think it's once a month, yeah.
Okay, so well, if they're feeling pressure in the bladder or abdominal pain, that could mean that it is backing up in there, and even though you do see urine in here, maybe if it's not a kink, it could still be not draining properly. Maybe the end tip of the catheter could be in a position, if the patient's laying this way and the end tip of the catheter in the bladder is up here, it's not going to drain the urine. So you can reposition them, and maybe that will help it come out. So they may, if they complain of the feeling of pressure or some abdominal pain, another thing to want to look at for is some discharge or bleeding at the catheter insertion site. We call that the meatus. Have you heard that term before? If there's blood coming out of there, if they complain of itching, burning, could mean an infection again. Could mean just that it's irritating. Maybe the catheter is being moved up and down, and you need to secure it better with enough slack to allow for the patient to move. Okay. Emptying the drainage bag, which is really all I was supposed to talk about.
No, that's
It's perfect.
Getting carried away. What's the first thing we're going to do before we empty the drainage bag? No? Close. That's number 2. What's number 1? Yes.
Watch.
Yes.
What is it?
That's probably number 1 in just about anything I'm going to ask, or anything anybody will ever ask you. That's always a safe answer. Wash your hands. You'll never go wrong with answering that first. Second would be to put on gloves. Again, That's for your own protection. It's really not gonna protect the patient, but it's for your own protection. You could do that. Okay, so we're gonna pull this out of here, and this is where the urine is gonna be coming out. Oh, this is a new fancy one. I'm not familiar with this. But anyway, we don't wanna touch this to anything. We don't wanna touch this to the inside of what we're draining it into, the hat or the cylinder. You don't want to touch it to the floor. You don't want to touch this with your finger, because that's where the cootie bugs go in, right? And go up, 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 all the way up. This is, huh?
Bacteria
Yes.
contamination.
This is the clamp, so you're going to want to, first you're going to get your container, then you're going to hold this over the container after you put your gloves. This is the last thing you're going to do when you make sure your aiming is good, okay? Do not touch the inside of the receptacle of the hat. And what else? This little contraption here. Okay, then we're going to put this back in here. Try not to touch the outside of the bag with this. We're going to try and get it right in this little clean spot in here. Okay, and then this should never be disconnected by you from the patient's catheter itself. This is a sterile point, and this needs to be done by a licensed person. And who knows what this is?
This is for tie.
Do you know what this is? The rubber band?
Connects to like a bed or something, right?
Uh-huh.
Tie
This
to
is the
the
patient.
clothes or the-
You're going to connect it to their pajamas or whatever, so that they can. Usually we move it up a little higher.
I'm not used to seeing that used.
I haven't seen one
Sometimes
of
they
those.
sometimes they just
It's
use
for
tape,
tie.
But I'm used to seeing tape.
and they just put it in exit.
Uh-huh.
Crisscross it, you can do that, but this is to connect it to the gown or whatever, and leave enough room so this patient can move this around and in bed, so that if it should kind of get laid on or stuck, it's not so tight like this. You would think that the looser it is, the more likely it's going to get caught on something. But if it's underneath the bed linens or underneath their clothes, the closer it is with a little bit of the looser it is with a little bit of slack is better for movement. Okay. And can we, okay, so here's the catheter tip, and it's in the patient, and here's our hat up here, okay, or right here. Pretend there's moving. We're going to take this out. Can we do this like this? What's wrong with this picture? We're holding this right here, like this, and here, and there's patient. What's wrong with this picture?
There's a post. It's too high. The first one.
Very good. Yes, we have to do this below the level of the patient to allow the drainage, because if the urine goes back up this way, once it's already out, that increases your chances for infection.
Below the waist.
Always, well, it should be below the level of the bladder,
Yeah.
wherever that
Yeah.
may be. And then this,
Well, they usually have it hanging down here by the bed, so
Uh-huh.
it's easy. There shouldn't be no reason to
let's
get
say,
it.
oh, I got a bad back, and this patient's got 1,000 cc's like of urine in here, and I just don't want to really do it down here, and there's a bedside table. I'm just going to pick this up and put it here and just go like this, and then I won't have to bend over.
That's a big no-no.
Mm-hmm.
You're either hurting yourself, plus you're hurting the patient too.
Right, right. And maybe your back, but then you take it, that's another whole story. Okay, and one last thing that they always talk about, this thing, you know what this is? This little
This for tie in the bed.
And do we tie it, can we hook it to the side rail right here?
Yeah, but there's
Or do we-
don't have a side
No, not
bed.
Not to the rail.
Bed
not to the
rail.
rain, not where you're gonna pull it down, no.
Because what might happen?
Cause you're gonna pull and it's gonna, probably go for now.
Pull
Yeah,
the
pull
patient.
out.
So always to the bed frame, not to the side rail? Okay,
Yeah.
I think that's about it. Any questions? Leaking, any leaking that you ever, if this is leaking, drip, 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 drip out of here, maybe the clamp is not tight enough, you need a new clamp. Leaking from where the catheter goes in, leaking from here, maybe in here, this connection is not tight, any kind of leaking needs to be reported right away.
Yeah, when it's leaking in the perineal area, we call immediately. Yes,
Yes.
we report.
Well, it's not an emergency. I mean, if the nurse is in the middle, I would let her know as soon as possible. You don't want that drip, that
Yeah, you
urine to
don't
be
touch.
underneath the patient on their skin, irritating their skin.
But we can touch.
Well, you can,
We don't have authorization for toilet.
no, but you can put a towel down there.
No,
But
I
not the, I wouldn't
not a
touch.
catheter.
No, not the
Okay.
catheter, no. Okay, any questions on that? Guys know a lot already. Okay, and the last one, here, I'll just hand you this. These are just, hopefully this is what I said. Urinary drainage bag. And then on this next page, we pretty much did all that. I hope I got all of those. And the next one is the colostomy. So, how much do you know about colostomy bags? Nothing?
What?
Lots?
Not a lot. I just haven't worked with them, like, personally. I haven't, like, with a
Ever?
patient. In school, yeah, but.
Okay.
There are different colostomy ways.
Okay, there are.
I've seen it in patients, people, but I never use one. That's when they do their poop.
Okay, so we should probably start from scratch on this, pretty much. Yes? Okay. So, first of all, why do patients have colostomies? They had their colon cut, okay. The colostomy is for, what are we collecting here? Mhm. Very good. Both are right. Okay. Okay, so there's many reasons why patients will have a colostomy, but we won't get into that right now. But the word ostomy itself means a surgical incision into through the abdominal wall into a part of the colon. It can be in the big part of the colon, the small intestine, the large intestine. It can be at any point along the line there, depending on the need for the purpose of why the doctor is doing it in the first place. So any cut in here is called a ostomy. Most common is the colostomy because it's with the colon, C-O-L, colostomy, colon. But there are others. There's an ileostomy. I don't know if you've ever heard that word. That goes into the, right, okay, good. All right, so colostomies can be both permanent and temporary, or temporary. The little thing that comes out of the stomach, part of the colon that comes out of the stomach, that little thing that they say looks like a rosebud. Very good, yes. Portion of the intestine brought to the surface of the abdomen to allow for drainage. So, what color is this? Stoma, red, or?
Pink.
Good, pink. Can be red or pink. And is it dry, moist? What is it?
Probably moist.
It's moist. It's part of your mucous membranes inside your colon, and especially when the feces is coming through, it's going to be moist in there. So this little thing that's sticking out here is supposed to be somewhat moist. Okay. When you clean around this, you don't like my humor?
No, it's his faces. It's really not that bad.
My
Yummy.
humor's not that
Oh.
bad?
No, he's making a face
stoma.
about the stoma.
Oh, okay. What did I say?
No, I'm hungry for lunch.
Okay, I'm trying to be professional.
Throwing you off your game.
Okay, so it can bleed when you clean, and especially if it's a brand new one that the doctor has just, done surgery on recently, a little bit of bleeding is okay. So there are different sizes and different shapes. Some can be bigger, some can be smaller, just like everybody is different. Their insides are also a little bit different too. But generally they're about that big around, like a golf ball. So this area that's right around the stoma is called the peristomal skin. And that should be kept clean and dry. No bleeding from that particular skin, no cracks, no ulcerated or like sores around that stoma, okay? And then this thing we call an appliance. And there are two kinds. This kind is the one piece, and this one is called the two piece. So this just comes like this, and they're both the same. If you have a real irritated skin around the stoma, you might want to just keep the one piece and not keep changing it, or you might want to use the two piece rather, and not keep changing it. I'll show you why. So if you have this stoma here, then they have this like a waxy pliable ring that goes right around the stoma, and usually it's a piece like this, and you cut, I don't know if you will cut, probably the nurse will cut a hole in it so that, because if your stoma is this big, you want it to fit snugly around the stoma. And if your stoma is this big, then you're going to want to cut it a little bigger. So you're never probably going to find a stoma bigger than this. So this thick piece of flexible material is called a Correa ring.
Isn't that it?
Right here. Sorry, I should have showed you. That's a Correa ring. So you'll get this separate. If you're going to be using this one, you'll get a separate one. So then this already comes already on here. So let me show you how this would do.
You can take it off.
I can pull it all apart.
No,
Okay.
you can take that.
Take
Just
this
the
off?
ring clips off, yeah.
Take what up? Oh, yeah. Okay. We'll do it like that. All right, so then you have the stoma, so you're going to clean it. Let's see what I got here. Okay, so we sometimes can call this a wafer, and this is the pouch or the bag. So then this comes with you'll tear this off, and then you maybe need to cut this a little bit bigger than this. This is kind of small for a stoma. So then you would let the stoma go through there, and pull, it'll come through, depending on the size, and then that goes on there like that. And make sure that it's very secure. This is just an adhesive type of a thing. And then, so then if this clips onto here, and you make sure that that's secure. You don't want any drips out of there. If it's not secure, you're going to get a pretty bad odor out of there. By the way, there are things that you can get on the market that they have tablets and things, droplets I've seen, that they can put in the bag that does control the odor. I don't think that has to be ordered by a doctor per se, but it just depends on patient's preference. So then this will clip onto here, and then once this is clipped onto here, you don't need to take this off. What your job basically is going to be is this is going to be rolled up, and it should have a clamp, which this doesn't, and it goes on here, and then the patient will wear this. And then you'll get different stool coming out of here. You'll get different colors depending on whether or not there's blood. It could be light or dark brown depending on what they eat, just like our stools are. The consistency will vary depending on where in the colon it is. The small intestine is usually very, very loose liquidy. The colostomy in the colon, you might get semi-formed stool in here. Some people it comes out just like a regular bowel movement. So it just sort of depends, but you're going to look for the same types of things as if it was coming out the other way. Consistent diarrhea when you know that this is a colostomy and it's in the colon. You might, if it's just really, really liquidy and a lot like a diarrhea, you can get diarrhea out of this as well. They suggest that you empty this every 2 to 4 hours. Only so that it's not so heavy that this is not really, I don't know, this is the new millennium. It seems to me like they should have some better thing for down here, but I see this hasn't changed for 25 years. But you don't want this to get so heavy that this is going to pop off and go all over the place. So don't let it get too full.
So when that gets full, when you change it, do you just replace it completely, right? You dispose of that, or do you reuse it?
No, you can reuse this. This is also not a sterile.
Just open the hole and the bottom.
Well, from time to time you will, just because it gets old
Yeah.
and raggy and like that. But no, you replace this. And then there's a belt, which there's little tabs here, that patients usually wear around their waist unless they're completely bedridden. But if they're up in a wheelchair or whatever, they'll have a belt that goes around that will hold this in place for them. Ideally, if you can get them to the bathroom, you kind of like go like this, and you don't even have to take this off of here. You can just open this up and empty it right into the toilet. That's really the best way to do it. Otherwise, you're going to need to use a bedpan. You just kind of, like you do with toothpaste, like that. And and then maybe I don't know. I didn't really research this, but I would say once a day, más o menos. I would take this off and put a dressing on top of the stoma, like this, and go run to the bathroom and rinse this out.
I was gonna ask that. Do we rinse that thing out again?
Yeah, and you definitely want to wear gloves. This is not an option. You definitely want to wear gloves with that. So room sprays are always nice. What I want to say about this that I think is important, and this is a real sensitive issue with patients as far as,
Dignity.
Yeah. And some are fine with it. Hey, this is my normal body function, and I mean, I've had people even make fun of themselves with it, and that's okay. Then there's other people. You try to give them as much privacy and respect as possible. And I personally like to encourage them as much as possible to do as much for themselves as they can. They're gonna ideally need to learn it on their own unless they're a deteriorating patient and you know that they're not going to be getting better. But with gentle guidance, I think that they should do as much as possible for themselves. If they're not comfortable with that, some patients, hey, you know what, I'm paying you, I want you to do it. And everybody's different, the customer is always right, so they say. So,
But I think the key is just communicating with them and telling them, kind of get a feel of how and where they are, right?
yes.
Before
How
you
do
just
feel
jump in
about-
and start doing it.
Yeah, how much of this are you, how much experience